Thanks for joining us this evening. Tonight, I'll be talking about hormones in the adolescence, the challenging landscape that most of us encounter in our jobs every day. My name is Lynch, and I'm one of the OBGYNs here at Hudson Physicians. So I was starting to gather information on this presentation. I wanted to affectionately rename it as the gynecologist rule for surviving puberty. As I gathered information, I found that there really is so much that goes on in this process, and so to learn more about it and to communicate and talk about it helps us understand, helps us engage and communicate with our adolescents or teenage gals a lot better. So in getting started, small slide here, lots of little print, but this is something that ACOG came out with just recently, and it's helping us to remind our patients and colleagues that there are numerous reasons why the young female should come to see a gynecologist. This pendulum has swung a bit though, so probably 10 years ago, everyone should be coming into the gynecologist as soon as they wanted birth control. And that was about it. That was the line. So that all became, or oftentimes was a bit threatening. And we were always doing PAPs as soon as someone came in. Now, new literature or something, we're supporting something different where we're only performing pap smears at age 21. But there is this gray zone in between where there's a lot to learn, a lot of information to gather, relationships to build in these young females before age 21. So 21 reasons why females should see a gynecologist before 21, and I will review many of those in this presentation. Here is a list of probably the 4 main things that I see young females in the office for. And that's heavy menses and painful menses. And I'm going to lump these two together as we continue on. Mood changes prior to and around the time of menses, and difficulty placing a tampon. These are the most common reasons that I see females in the office, and we'll touch on all of these in detail. But first I'd like to start with puberty, just an overview of what this process is, what it all means. So a series of physical, psychological, and emotional changes signaling transition from childhood to adolescence. Numerous different processes going on. Again, there's the physical component of it. Physical growth and development, changes to sexual organs, brain changes, and then the social and emotional changes. So puberty is triggered by changes in the child's brain that causes hormones to be released from the ovaries. This process usually starts between the ages of 10 and 11 for girls and 11 and 13 years for boys. But it's variable. Start of range from 8 to 13 in girls. Here's some science here. So the hypothalamus, the structure in the brain, controls action of the pituitary gland, another structure in the brain. And this produces these necessary hormones to start this change. It acts like a thermostat regulating the sex hormones, and from there, as the brain, the hormones that are produced in the brain stimulate the pituitary gland, which then subsequently move to the ovaries, and the ovaries then respond and produce estrogen and testosterone. All kind of complicated, and here's the schematic of that again, getting a little sciencey on everybody here today. But it's interesting, and what is interesting about it is it's incredibly complex. So we're dealing with a child that's dealing with a very complex process to transition into adult, and it translates into all the complexities that come with puberty. So as I had mentioned, between 10 and 11 years old is when this process starts, and you usually see it with the onset of breast development. So that is usually the first sign of the change into puberty. Then comes growth spurt, so 5 to 20 centimeters on average. This height usually peaks for females between the ages of 16 and 17. Hips widen and changes to external genitalia. Next steps between 12 and 14 years of age, and this is usually 2 years from that first sign of change of puberty or breast development, comes here at the armpits, vaginal discharge, and starting the period, or menses. And then subsequent to that comes all of these changes at every system. So you see changes of the brain, self-control, planning, problem solving. We could have a hour-long discussion on this. I mean, of course, we see this all the time, where difficulty with relationships, difficulty in just transitioning into an adult in a child's body. So a lot of challenges that come at that level. And you can sometimes see clumsiness. So bodies are changing, and the neurologic and muscular system are trying to keep up. So you can see some clumsiness with that, maybe more injuries in a sport setting. Physical strength changes, weight changes. And this is, paramount here with how we teach our young girls about diet. What are they eating? What's important? What's going to be a balanced diet as their needs increase? Sleep patterns change too, and we see this, and large studies have support that children in their teenage years need more sleep. So we should encourage teenagers to, and oftentimes their sleep cycles change too, so they're going to bed later and sleeping later. This is common, normal. Sweat glands change, so hygiene, it's going to be something that we want to teach our young girls about, how we can maintain this because of the changes in the sweat, their sweat glands, and skin and hair changes, or oil production, again, just speaking to hygiene. So when all of this process starts, now we're looking at how there can be complications or issues that arise from the changes in puberty. And as I mentioned before, coming back to this, most common reasons that I see patients in my office would be menstrual changes. So heavy menses, painful menses, I'm going to lump these two together because they're common complaints. Menarche, or first menses, occurs 1 to 3 years after the start of puberty. And as I had mentioned in that previous slide, you can time things usually by that first breast development. So usually once you see that change, then you're going to anticipate menses within the first 2 years. Cycle length can be variable, but 21 to 45 days is normal. And that's from the beginning to the beginning of the next cycle. They should be regular by 2 to 2.5 years of the start, or menarche, or the first menses. Cycles outside of this 21 to 45 days, though, should be considered abnormal and would be a reason for evaluation. Duration is usually 3 to 7 days, again, that week period. If it goes longer than that in duration, probably should be evaluated. Then the average blood loss is 30 milliliters. That range can be from 20 to 80 milliliters. This is a hard thing to conceptualize, create an objective answer. We ask this all the time in the clinic. How much are you bleeding? People estimate that differently. They experience it differently. So there'll be some questions here in the next upcoming slides to try to quantify that better, to understand whether it's normal or abnormal. Again, another science-heavy slide, but again, trying to express the complexity in the cycle and how it changes. So we're talking about 3 different systems from this slide. The first line describes what's going on at the brain. The second line is the hormone fluctuation that happens at the ovary from the stimulation from the brain. And then the bottom slide, that line looks like a roller coaster, is what our endometrium, or the lining of the uterus, is doing. So you can see here there's a buildup of the lining and from stimulation from the ovary, and then ultimately that lining builds to support a pregnancy if it happens, and if it doesn't, then it's shed. So over half of adolescents will take up to 2 years after the first menses to have regular cycles. Adolescents with later onset of menses, when this process starts later in age, they have longer intervals until the cycles become regular, and this all has to do with the immaturity of this HPA axis is what we call, but what it means is just that brain, ovary, uterus connection. So here are some reasons for evaluation. Like I said, it's sometimes hard to know what's normal. Everybody describes or experiences their menses different, but some things that stand out would be worthy of evaluation: a period lasting greater than 7 days, feeling of flooding or gushing for most cycles, when your activities are limited by menses. So I oftentimes ask people that question. When you do have your period, how many days are you missing school? Are you so incapacitated by it that you can't participate in sports? If you would have bleeding problems after dental surgery, any type of surgery for that matter, might be a worrisome finding and something that should be evaluated further. Or if your family history is significant for some other bleeding problem. So this is a short list. This could be expounded on, for minutes and hours, but treatment for heavy and painful menses goes a little like this. So we usually try anti-inflammatories at start, especially if there's pain is the primary symptom. Then oftentimes we'll go to a combination oral contraceptives. This is a medication that can help to regulate the cycles, and with regulation, and we're kind of trying to control the swing of hormone that happens at the ovary. Progesterones alone can do this, IUD, and dietary or behavioral changes. So another point that I wanted to touch on as a more common reason that we see people in the office is mood changes prior to or during menses, often termed PMS, or Premenstrual Syndrome. And this is described as physical or mood changes that occur several days before and resolve within days of starting your menses. So a short definition for a long list of symptoms. As you can see here on this list, it can go from depression, angry outbursts, irritability, crying spells, confusion, poor concentration, increased nap taking. So wide variety of symptoms, but some can be quite severe. Again, back to my schematic here of what's happening in the body, though. As you can see towards the end of the slide, the middle, the lines that are red and pink, this is what's describing what's happening at the level of the ovary. And that pretty significant drop towards the end is what is likely causing that kind of catastrophic change in symptoms. And from there comes physical symptoms. So women of any age, around the time of, if they're experiencing PMS, can experience thirst, appetite changes, breast tenderness, bloating and weight gain, headache, aches and pains, fatigue, skin problems, and even gastrointestinal symptoms. But again, the definition describes that these resolve usually at onset or just within a few days after starting your period. And here's some treatment options would be relaxation techniques. So trying behavioral changes, meditation, especially when it comes to the depression, anxiety, mood changes that often transpire in those days before period. Yoga, massage, acupuncture. And there's medications too. We come back to the combination oral contraceptive. If we can control what's happening at the cycle, override that large swing of estrogen, progesterone, drop that happens at the end of the cycle. Sometimes this can be very therapeutic for people. Also, sometimes an antidepressant is considered in those last 2 weeks of the cycle as those symptoms start to increase nearing menses. Also, it's good to focus on diet, behavioral things. What can we control without medication? Eating a diet rich in complex carbohydrates can be beneficial. Also, increasing calcium intake probably has some impact on our muscle health. So increasing calcium with dairy and leafy green vegetables, reducing intake of fat, salt, and sugar, avoiding caffeine and alcohol, change eating schedule to 6 small meals a day, so eating small and frequently, and also sleep hygiene again, so coming back to that consistent sleep pattern. Also, getting a full 8 to 10 hours is what's recommended for teenagers. And I did want to touch on just the difference between, there's 2 different diagnoses here. Premenstrual syndrome, as I had just described, is something different than premenstrual dysmorphic disorder. So this is a true diagnosis that has more severe symptoms. And I won't read through all this slide, but one example would be, in contrast, a girl with PMS, maybe more emotional, find herself crying at things like sex commercials, where a girl with PMDD or dysmorphic disorder is likely to experience feeling similar to depressive episodes with feelings of hopelessness, worthlessness, misery, even suicidal thoughts. So a much more severe onset of symptoms, but again, they resolve. So the diagnosis is where it is cyclical again. These kind of situations, though, require much more probably intensive scrutiny, therapy, involvement, and treatment. Because oftentimes what people describe is they overcome this, they get through it, they start their menses, symptoms improve, but what lingers is really what they've done to deteriorate relationships, school, participation in sports, everything that they were involved in really derails once the period starts. So lastly, in my list of most common reasons for a gynae visit is difficulty placing tampon. And this one sounds a little bit funny, but we see it quite often where girls are involved usually active in sports or other extracurricular activities, are ready to try to use a tampon to allow for less difficult pad wearing, allows them more ease in participating in these events, and they cannot place the tampon. It probably involves a lot of stress. Oftentimes physical discomfort, moms helping, sisters helping. Finally, they reach a point where they're frustrated and they come to our office. And it can be a problem with something called an imperfect time, or some variation on that theme, where there's a small band of tissue at the entrance to the vagina that can block menstrual flow completely or partially, or also make a tampon difficult for placement. If untreated, it can cause a long list of problems, but sometimes endometriosis, pelvic pain, stigma with tampon use. And treatment is simple. It's usually just a surgical procedure, or it may bring to light a more complicated picture. Sometimes there can be more issues beyond that little septum that's in place. So in closing, I wanted to just bring it back to reasons why we want to visit our local gynecologist. At START, it's for information. So we want to educate young girls. This is why we entered into this field and feel it's important to establish that relationship early on. By seeing girls at that age of 13 to 15, we can start to establish that relationship before an exam is necessary. So providing confidentiality, accurate information, not just friends, information they're hearing from friends or neighbors. And then prevention, so pregnancy prevention, sexually transmitted infection prevention, and just maintaining a healthy lifestyle. And then treatment for these things that I had mentioned as the most common reasons that females come to our office. Heavy, irregular, painful periods, pelvic pain, vulvar problems, all can be, are addressed every day in our gynecologic office. And in closing, just wanted to reiterate too, as we talk about prevention, sometimes there's a hesitancy to bring the young girls into gynecologist's office, as they fear that talking about sex might provoke sex or there's, promiscuous behavior. It's actually the opposite. What's really exciting is that we've prevented or have decreased, not prevented, but decreased teen pregnancies by a tremendous amount. The numbers are huge. 64% from 1991 to 2015, teenage pregnancy has gone down tremendously. And there's speculation as to why that happens. It's probably cumulative, but it's likely a lot of education. So increased teen abstinence, so that's going up, which is wonderful, and contraceptive use. And we haven't stopped talking about it. Education continues to try to get better. There's demographic around it though. The United States continues to have higher rates than other industrial nations, and this is definitely affected by socioeconomic class and race. But this is a graph just to describe it. It's plummeted. So from the ages of 15 to 19, that's what you consider teenage pregnancy, has gone down dramatically, and especially in the ages of 15 to 17. So again, bring this picture back up just to remember that there are numerous reasons why we should come to bring our girls to visit the gynecologist, not only for contraception, not only for a pap smear, but just to build that relationship and start the communication early. Thank you.